Good morning, everyone, and welcome to our TIRO multidisciplinary seminar program. I am particularly excited about our panel and our presenter this morning. We've got a lot of ground to cover. Basically, we've got a century's worth of thyroid surgery to get through in 1 hour. But fortunately, our guest presenter this morning, Dr. Sareh Parangi, is going to cover that masterfully at the outset here. So I would like to introduce our panelists. First, Dr. Sareh Parangi is professor of surgery at Harvard Medical School, and she is chairman of surgery at Newton Wellesley Hospital. She has a very busy endocrine surgical practice at Massachusetts General Hospital. She is the 2023 recipient of the Harvard Medical School Joseph D. Martin Dean Leadership Award for the achievements for the advancement of women's careers. She is also the president-elect, a truly wonderful honor of the American Association of Endocrine Surgeons. Dr. Parangi and Dr. Orloff are the co-authors of this morning's paper recently published in Thyroid. This morning's panel includes 3 members of the TIRO Medical Board who have appeared often in our Friday programs. First, Dr. Carrie Cunningham is an associate professor at Harvard Medical School and section head of the MGH Endocrine Surgery Unit. She is also a senior scientist at the Massachusetts General Hospital Institute for Technology Assessment. She has served on the executive council of the American Association of Endocrine Surgeons, and she served as president of the Association of Academic Surgery. Dr. Mark Zafereo is a professor of head and neck surgery at MD Anderson Center, where he is the section chief of head and neck endocrine surgery and associate medical director of the Head and Neck Center. He is a member of the board of the American Academy of Otolaryngology Head and Neck Surgery, as well as the International Thyroid Oncology Group. And finally, a man who needs no introduction, Dr. Ashok Shaha is the attending surgeon at Memorial Sloan Kettering Cancer Center, where he has spent the vast majority of his career. He has held numerous national and international positions throughout his illustrious career. He is perhaps the most widely published academic surgeon that I know. He is an outstanding teacher of medical students, residents, and fellows, and has received awards in acknowledgement of his efforts and commitment. Dr. Shaha is widely recognized for his expertise, but one of the things that is not widely recognized is his avid enthusiasm as a Taylor Swift fanatic. While he has lectured throughout the world, I went back and looked at his lectures and compared them to Taylor Swift Aries Tour, and they match up perfectly. And so I am, Ashok, I hope you don't mind, I'm disclosing it here this morning, that you are one of the most loyal Swifties on the planet. And with that, I am going to go ahead and turn over the panel to the program to Dr. Parangi. And just a brief note, Dr. Parangi will be leaving right at 8:45, and so she'll take part in the early discussion. And then, as always, I invite all of our guests to send in their questions and comments, and I'll do my best to get to them. And so with that, Sarah.
Thank you so much, Mark. It's wonderful to be here with everyone this morning, and my apologies in advance for having to move to a different obligation in 45 minutes. So this has been a labor of love, talking about the evolution of thyroid surgery in the last century. I have no disclosures to make relevant to this talk. So we were asked by the editor of Thyroid, Lisa Orloff, and I to write a short paper on 100 years of thyroid surgery and sort of the transition to modern surgery, how it became safe, effective, and increasingly refined. I know Lisa couldn't be here this morning, so we kind of are exhibiting our talk together just to speak. And they did choose to put the cover about this, and I'll show some of those pictures as well. So big thank you to Lisa and big thank you to you all. So I'd say, before the 100-year start, there was what I would call the dark ages of thyroid surgery. So early 19th century, thyroid surgery still needed to be done, but only with a very high rate of mortality, and really was considered basically butchery when thyroid surgery had to be done. There was very strong public and medical opinion against doing thyroid surgery, as essentially mortality was as high as 40% or more when it was performed. Of course, surgeons, had nothing. They had no anesthesia, they had no methods of infection control, and they had no methods of blood loss management. And here's a quote in the 1920s from Dr. Halstead. So just before where our century starts, where he writes that the removal of the thyroid gland typifies perhaps better than any operation the supreme triumph of the surgeon's art, a feat which today can be accomplished by any competent operator without danger of mishap, and which was conceived more than 1,000 years ago. There are operations today more delicate and perhaps more difficult, but is there any operative problem propounded so long ago and attacked by so many, which has yielded so bountiful and so adequate a result? So he's really talking about the century and what is starting to happen at that beginning of the century, a big change from this very high mortality and butchery type of idea to a more refined kind of surgery. And really, of course, we can't talk about thyroid surgery without talking about Dr. Coker and his legacy. So Dr. Coker is certainly the number one person that comes to mind when you think about changing thyroid surgery from what it was to what it is. Dr. Coker plays a pivotal role in all kinds of areas. So focusing on meticulous surgical technique and what influence it has on thyroid surgery, also focusing on not discovering the parathyroid glands, but focusing on the importance of preserving the parathyroid glands during thyroid surgery, understanding thyroid physiology, and really understanding thyroid hormone. And here, of course, is the famous picture of the two sisters that he operated on. So on the left is the younger sister and the older sister, with the older sister undergoing thyroid surgery by Coker, and him seeing the patients in follow-up a few years later and noting that the older sister had remained stunted in her growth, had developed a round facies, had become cognitively impaired 9 years after the operation, whereas the younger sister, who had not had the thyroid operation, had gone on to have normal development. And this got him thinking, of course, about what the thyroid was doing and why, when it was surgically removed, this child had become stunted and dwarfed and developed typical myxedema symptoms and signs. And so that got him thinking about thyroid hormone replacement and using bovine thyroid extract to feed people who have thyroidectomies. And of course, up here, we see that the kinds of goiters that were being operated on at that time were these ginormous masses, which truly would scare any surgeon, even with all of our accoutrements. And of course, Coker invented the Coker incision and developed the concept of subtotal thyroidectomy to avoid hypoparathyroidism and hypothyroidism. All of his work culminated in him winning the Nobel Prize in Physiology and Medicine in 1909. And he still, to this day, remains one of the few surgeons who have won the Nobel Prize. The next group of breakthroughs are all related to important concepts: anesthesia, antisepsis, and hemostasis. And these innovations collectively helped us lower the mortality and morbidity of thyroid surgery. So in 1846, anesthesia was introduced, and this is not a real picture, but it is a 1846 reenactment of the first anesthesia given for a neck operation at MGH. And then Dr. Lister started the antiseptic techniques and really changed surgical technique globally. This was adopted in the late 1800s. Sterile surgical instruments and environments were developed. And here on the right, you can see Dr. Coker here wearing rubber gloves in 1914. And here you can see his assistant wearing a head covering so that you don't get hair and beard and everything into the wound. And then the role of hemostasis and postoperative infection control was also coming into play. And of course, we can't let forget to mention the discovery of the parathyroids and their preservation. Dr. Sandstrom was a medical student when he identified the parathyroids in the 1880s and really just helped work on the crucial role of the parathyroids in calcium metabolism, along with many others along the way. And really, Cope and others emphasized the parathyroid glands being preserved and identified techniques for preserving them during surgery. What was happening on this side of the pond in the US? A lot. And here I'm just going to go over a few things. So one critical person in thyroid surgery on this side of the Atlantic was Dr. Halsted. He was very instrumental in, again, developing very, very meticulous techniques in the neck, describing the anatomy and making sure that people started specializing in the care of thyroid cancer and goiter patients. And here you see one of his original figures in 1920, where he describes the anatomy of the neck and is describing from posterior the position of the parathyroids. And he wrote, "It seems hardly credible that the loss of bodies so tiny as the parathyroids should be followed by a result so disastrous." And then Dr. Leahy in 1927 also played a critical role in making thyroid surgery safe in the United States. Of course, he was the founder of the Leahy Clinic as well. I'm going to focus a little bit on Dr. Cope because in endocrine surgery world, he does hold our highest meritorious award, the Oliver Cope Award of the American Association of Endocrine Surgeons. And he was an MGH surgeon. He was really a visionary in many, many areas. And in fact, the talk I'm supposed to give at 8:45 is about his life and in many other areas. But the reason that he is given the honor of having the highest award at the American Association of Endocrine Surgeons named after him is for his work in parathyroid. So he was a resident at MGH in the 1920s and early 30s, became an attending during a time when surgery was very generalized initially. Every surgeon was thought they could do every kind of surgery. But his chief, when he was a resident, Dr. Churchill, really changed that at Mass General and assigned surgical residents to study certain things. And Dr. Cope was assigned to study neck surgery, thyroid surgery, and specifically parathyroids. So he spent 3 years studying the parathyroids with pathologists and a medicine resident, and really understanding what their role was and how they could be found. And in 1935, he wrote a paper for the New England Journal of Medicine describing what he thought at that time was the importance of parathyroids to the surgeons who were doing both thyroid and parathyroid surgery. So I'm just going to paraphrase a few of the things from that paper. So he did write that parathyroid surgery is not the same as thyroid surgery, and that every surgeon versed in thyroid surgery realizes the difficulty of recognizing parathyroid tissue. It is one thing, however, to avoid the removal of parathyroid tissue in performing a thyroidectomy, and quite another to expose and identify all of the parathyroid tissue present. So I think this was very important because, in a way, he linked the thyroid and parathyroid surgery together, and yet they're very different from each other. He also wrote that removal of all parathyroid tissue resulted in tetany and possibly death, and there was no hormone replacement therapy that was effective. And remember that during this time, right, we had World War I, and shortly thereafter World War II. Communication between continents was not easy, and what was being written on one side of the Atlantic wasn't necessarily getting communicated to the other side. Here's another very important surgeon in the evolution of thyroid surgery, Dr. George Kreil. He's wearing glasses here at the Cleveland Clinic. He was the founder of the Cleveland Clinic. And here is his son, the third from the left, who went on to also become a very great surgeon. In 1936, here at Cleveland Clinic, he was performing his 25,000th surgery. And just to tell you that these clinics, Cleveland Clinic, Mayo Clinic, Leahy Clinic, were all founded essentially on a volume of surgery, which was for the most part thyroid surgery. And here, if you take a little look at this light, you see this little sphere of light is being held by this nurse up here. She's holding the sphere of light in her hand because the surgery was too dangerous to move the patient out of the room they were in. This is not an operating room. So a light had to be brought in and held by the nurse during the surgery to be able to perform the surgery safely. I'm going to talk a little bit about other revolutions that helped thyroid surgeons. So, of course, the Bovie. We all love the Bovie. So Dr. Bovie helped design this wonderful instrument in 1920. And it really changed the life of, I think, thyroid surgeons and revolutionized the control of effective hemostasis. Now we, of course, have many other energy devices. I just put a picture here. Pick your favorite: ligature, harmonic, thunderbeat. But basically, these are ultrasonic energy-based devices that allow us to control the energy safely for sealing blood vessels, and therefore minimizing intraoperative and postoperative complications. These opened new frontiers, I think, for us to be able to control hemostasis and to be able to do the surgeries faster and more efficiently with the aid of trainees. I don't want to leave out, surgeons worldwide who've been incredibly important in defining the safety of thyroid surgery. So I'm just going to put one up here: Dr. Dunhill, an Australian surgeon who was also working during this period, who really focused on this concept of the Dunhill operation. And that, we've kind of gone away from that, but definitely there was a significant period of time where that was the operation of choice for many surgeons. And over time, everything, every kind of thyroid surgery has been done, basically subtotal resections, bilateral subtotal resections, hemithyroidectomy, a thyroidectomy, and the Dunhill operation. So a wide variety of operative techniques have been used. The next big thing that really has made a huge change for thyroid surgeons is, of course, imaging. So radionucleotide scans started in the mid-20th century, differentiating between hot nodules and cold nodules. But really, it was the advent of ultrasound in the 1970s that revolutionized the precise anatomic and vascular detail that surgeons use today. So as you can see, this is actually the first ultrasound image of the thyroid that was published in 1971. And you can see that it was very crude, but you could kind of make out the right lobe of the thyroid here and the left lobe of the thyroid here, and then the trachea or vocal cord area here. Now, of course, we also have cross-sectional imaging, such as CTs, MRIs, and PET scans to help us with pre- and post-operative assessments of thyroid cancer patients. And then in the use of ultrasound for guiding our fine needle aspiration is also a relatively recent development in 1977. Of course, fine needle aspiration had been developed in 1948 and had been used, but making it more precise became a mainstay of the workup of thyroid nodules for surgeons. Another thing that I know is going to be a big part of the discussion here, and both Dr. Lubitz and Dr. Shaha will be commenting on this, is this concept of thyroid cancer detection. It's a double-edged sword. On one hand, you want to find the clinically significant cancers and make sure that they are removed. On the other hand, you don't want to overtreat or overdiagnose people. And clearly, countries like Korea that instituted screening have demonstrated to us that while the number of cases of thyroid cancer dramatically increase when you institute thyroid screening, the thyroid cancer deaths remain the same, implying that, of course, we're not helping anyone by removing these cancers any earlier at all. And this is now, quite well talked about in the press. Here's an example from the Nightly News, for example, talking about, basically how you shouldn't let surgeons take out your thyroid cancer, and be wary of this concept of overdiagnosis. I think surgeons have been instrumental in helping be part of guidelines and large groups, which have gotten together in the last 2 decades, making recommendations anywhere from radiology guidelines to active surveillance guidelines. Of course, now we have the TIRADS guidelines helping us to reduce unnecessary biopsies. We have active surveillance protocols, which of course we really owe to the Kuma clinic and the surgeons there that initiated those studies. Surgeons like Dr. Shaha and many others that really showed us that hemithyroidectomy is safer for a large group of patients, and that we should stay away from total thyroidectomy when possible and not to overtreat. And then now, of course, the new onset of ablative techniques, both for thyroid nodules and thyroid cancer, which I'll briefly touch on in a couple minutes. So I guess what I'll say is that surgeons have been central in innovation in thyroid nodule care, in thyroid cancer care, and in the care of thyroid patients. We have all tried to make thyroid surgery more precise, safer, easier, faster, and more personalized, as well as more bloodless, and also a little bit prettier and a little bit more cosmetic, which, of course, is serving our patients. What innovations have we been part of in addition to the ones I've already talked about? We have been involved in parathyroid autotransplantation, therefore lowering the readmission rate for hypocalcemia. We've been very instrumental in measuring post-op PTH after thyroid surgery in order to decide whether the patient should be on Rocaltrol or not, so to lessen readmissions. We've been very involved in looking at the role of infrared technologies to identify and preserve normal parathyroids. So here on the right, you see a picture of a parathyroid, which is then fluorescing and able to be seen better, especially if it's on the specimen and can be auto-transplanted. And then, of course, there's also nerve monitoring, which has been very centrally involved with surgeons to try to develop techniques to identify the nerve and help reduce the risk of vocal cord paralysis. I just put here two surgeons that I think have been very critical in this area. Dr. Randolph and Dr. Durali have both really moved the field forward, both in intermittent nerve monitoring and as well as continuous nerve monitoring. And there are many, many things that nerve monitoring can be used for. It's not just binary yay or nay. So early nerve identification and mapping of the nerve. I personally find this very helpful when I have surgical residents or fellows trying to understand whether a nerve is being stretched too far, especially when it's a difficult or long case. You can do documentation of the function of the nerve at the end of the case. You can also prevent bilateral injury of the nerve if you are very meticulous about never moving to the opposite side until you've confirmed that the nerve is working on the first side that you start with. So I think in general, this has been a big change in my lifetime. I know that, when I first started my career around 1998, I went to Canada to learn nerve monitoring because nobody in the United States was doing nerve monitoring at that time. And when I came back with that technique around 2000 to the US and started practicing with it, I think it was used by an extremely small percentage of patients in the first I'd say 7 to 10 years of my practice. But now I think the tide has changed. I think most thyroid surgeons, somewhere upward of 70% are now using nerve monitoring in some capacity. Most are using it for every case, but some use it selectively. There's also the evolution of minimal access thyroid surgery. Please note that I'm not calling this minimally invasive as it was initially called. So if you look at the initial terminology with the Italian and the original video assisted, it was called minimally invasive. But in reality, it's not that minimally invasive, but it is minimal access, and the access sites are at different locations. Robotic thyroidectomy, I think, has been a huge development, really coming from Korea and the Far East, where cosmesis is very, very important to the patient population, especially young women, especially as Korea was doing the screening and the number of operations were dramatically increasing. Here you see a picture of the setup of robotic surgery and where the incisions are in the axilla and in the areolar area, and tunneling is made up to the neck, and the surgery is done up in the neck. There has been very good studies looking at the comparative outcome of traditional versus these kinds of robotic techniques, and they are very safe and very advantageous, really, from a cosmetic standpoint. I'm just showing this very short video of how this looks. So up on the screen, you can see the surgeon is manipulating the robot. The surgeon is nowhere in this field. The surgeon is sitting at a console and is manipulating the robot and able to work deep in the neck. And then we also have, of course, the transoral surgery development. Dr. Anawag from Thailand was critical in this area. And in this case, there is no scar visible at all because the scar is only in the mouth. And the surgery is performed entirely through transoral ports. And again, the benefit is really cosmetic. So here we can say, in general, when you think of minimally invasive surgeries such as laparoscopic surgery, vaginal hysterectomies, robotic valve replacements, generally speaking, they result in lots of benefit to the patient, often shorter hospital stays, earlier ambulation, less narcotic requirements, lower complication rates, reduced mortality. But really, for our thyroid world of minimally accessed surgeries, there's really just one benefit, which is no visible scar. And there is a very steep learning curve. So I think it's been one of those areas which I think is still in evolution in thyroid surgery because of the steep learning curve. I am going to talk a little bit about the role of surgeons in genetics and use of genetics as an adjunct for thyroid surgeons. Thyroid surgery has been instrumental in looking at personalized treatment plans. So medullary thyroid cancer was the first cancer to look at the genetic phenotypic correlation. Dr. Sam Wells was a surgeon who was instrumental in this area. And medullary thyroid cancer was really the first with prophylactic thyroidectomy to really contribute to this concept of operating on someone who doesn't have cancer yet based on their genetics, and really correlating a prophylactic surgery to the genes. And the reason that it worked was because thyroid surgeons were able to do the surgery with extremely low morbidity and extremely low mortality. And there was hormone replacement for that organ. And there was a biomarker that allowed follow-up strategy and early intervention strategy. So really, if you look at all the original papers, I do think that surgeons played an incredibly critical role in collecting the families, understanding the disease, and actually performing some of the original genetic work that now allow us to really treat these children long before the disease is evident. And of course, this has now become an important paradigm for many other cancers. I know usually what I hear is everyone's talking about BRCA1, but really I just wanted to emphasize that people like Dr. Wells were pioneers in this area for thyroid cancer. The other area that I do think thyroid surgeons have been really playing a pivotal role is this concept of molecular testing. course, we haven't done it alone. This is a huge area of research with huge contributors in medical oncology, basic scientists, the National Institute of Health, pathology. I mean, I can't name enough people in this area, but I think I'm proud to say I do think surgeons have also played a role in making sure that we contribute to this area of precision oncology. There's been several talks in this journal club on this area, so I'm not going to belabor the details of this. But of course, genetic markers and helping stratify what we do with patients. Do we do one kind of surgery or another surgery? Do we remove lymph nodes or not? Do we even take the nodule out? Has been very, very critical, the molecular diagnostics. The evolution of the molecular testing has made a huge difference as more and more genes have been found and put into these commercial panels. More and more specificity and has allowed us to be more precision-oriented surgeons. And of course, now I think surgeons have to really ask routinely the question, am I going to do something with these molecular markers? If not, of course, we shouldn't be doing the test. If we are going to use them, then we should really understand all of the different aspects of it. And I think it's very important now to note that really the molecular signature of the tumors is helping us risk stratify disease recurrence and therefore the kind of therapy we might consider both as surgeons and also in the postoperative period. So these molecular signatures are in parallel to the risk that we see as we decide what kind of surgery to do. And I think this is a big area that will, moving forward, continue to affect surgeons. So again, just the different areas of mutations that we can look at and try to decide whether preoperatively we want to do a hemithyroidectomy or a total thyroidectomy or take lymph nodes, depending on the mutational profile, can be helpful. Of course, in some cases, not in every case. And I think this is an area where surgeons are learning along with our molecular pathology colleagues. I think another area which I think Coker emphasized early when he started the field of thyroid surgery is sort of integrating multidisciplinary care and working together for both benign and malignant thyroid disease. Here is a picture of the MD Anderson dream team of anaplastic thyroid cancer care, which Dr. Zafereo here is a big part, and several of my good friends are. And so really working together as teams and not in isolation as a surgeon, making sure that we have patient-centered decisions and we have this sort of specialized clinics, whether it's specialized in RFA, whether it's specialized in aggressive cancers, and therefore speed matters, like this FAST team at MD Anderson. I think really meeting together, working together in teams is a concept that, you know, goes all the way back to Coker, but we are continuing it today. Here's an example of RFA in our institution. So thyroid ablation is now being used increasingly frequently for benign thyroid nodules. This is a technique which essentially puts radiofrequency energy into the thyroid nodule and slowly ablates it when they're small and but still bothersome to the patient and benign. It's a short outpatient procedure. No general anesthesia is required. It's less invasive. There's no scar, and there's a shorter recovery time. But just to show that, again, I think in a multidisciplinary way, this is done more safely for the patient. So here's Dr. Gartland, Dr. Tabbitt, an interventional radiologist, and Dr. Barbacino, an endocrinologist. So surgeon, radiologist, and endocrinologist working together to move this field forward. and really the program development. I'm just going to briefly show the amount of effort and working together that it takes. And this is Dr. Gartland's baby, but really to develop these kind of programs is a lot of effort, a lot of working together. And I think thyroid surgeons over the last 100 years have been doing a lot of this kind of work to move the innovation forward. I think another area where working together has been helpful is sort of this treatment of advanced thyroid cancers. Again, I know all of you in this journal club have had several talks on sort of targeted therapies and immunotherapy. But in reality, how is this affecting thyroid surgery as these various inhibitors have been developed, BRAF inhibitors, MEK inhibitors, as well as immunotherapies? How it's been affected is these kinds of cases. This is a case from MD Anderson that Dr. Cabanillas shared with me, and I think Dr. Zafereo is familiar with. Here is a case where, you know, a patient has a ginormous anaplastic thyroid cancer, is having difficulty breathing. Our very rapid testing is done by that fast multidisciplinary team. The patient has a BRAF mutation. BRAF and MEK inhibitors are started. Dysphagia and shortness of breath subside. The patient's better for, 30 days, but then has progression again. More things start growing, more lymph nodes, more growth. Immunotherapy is started. And then eventually the patient is able to actually have a resection and have the mass removed and is alive 2.5 years later. And I think we can all say very clearly as thyroid surgeons that a patient with an anaplastic cancer this big a few years ago would not have lived more than a month. And now this patient, due to the combination of multidisciplinary care, the research on these agents is alive. And here's Dr. Zafereo's clinical trials that have started showing that this is not just a one-of. Patients are now getting these therapies and are able to have resection and are able to survive out to 1 year, out to 18 months, about 60% of the time. And I know that this work is ongoing and is showing a lot of results. And here's a case actually of Dr. Cunningham's that I'm showing here. Another case of ours where there was a massive amount of tumor burden in the neck, in the rest of the mediastinum, inside the trachea. We started with multiple BRAF and MEK inhibitors, added immune therapy. The tumor melted and actually a fistula developed between the airway and the skin. This is not a tracheostomy that we performed. And eventually the tumor melted away. And this patient is also alive now a few years later. So remarkable changes in this area. And I'll just put a plug in for surgeons doing research. This is my area of research. I'm very interested in this area, and where I think surgeons have contributed is in developing animal models such as we did. So we in 2018 and again in developed all these protocols for doing this work in animals and proving that in animals combining, for example, BRAF inhibitors, MEK inhibitors, and immune therapy works. Combining lenvatinib and immune therapy works. And from our work, as well as the work at Memorial, in transgenic animals, the ideas came for starting these studies in humans. And of course, that's taken off beautifully, giving the examples that I was able to give about specific patients really benefiting in aggressive thyroid cancers. So with that, I conclude my talk. I think we have a lot to be proud of. I think surgeons have done a lot of work, and I'm certainly thankful to my mentor, Dr. Clark, who passed away. He always made everyone feel special, and I miss him a lot. And he reminds me of this Maya Angelou quote, I've learned that people will forget what you said, people will forget what you did, but will never forget how you made them feel. And I think he's the perfect example of a thyroid surgeon who always made everyone feel special. And a big thank you to our team here at MGH, both our whole team and our collaborators, our residents, our fellows, who are all wonderful to work with. So I'm going to end on that and open the panel for discussion.
Great, Sarah, thank you so much. I'm going to invite our panelists and see if I could have you unshare your screen so that, there we go, I can go ahead and bring mine up here. All right, Sarah, thank you for that wonderful overview and really taking us through what has been just an incredible journey, and seeing where we've come is really quite astonishing. For those of us who have lived through some of this journey, you can't help but read an article like you and Lisa put together and think about our trainees who are coming onto the scene of thyroidology and thyroid management in 2024, essentially parachuting in and not understanding all of these amazing developments that have taken place that we just now take for granted. You know, these are part of what our everyday life, and the immense amount of work and research that went into getting to this point should never be taken for granted. So what I'm going to do with our panelists, and again, I'm just to everyone know, Dr. Parangi is going to be leaving us, but again, I do want to thank her for putting this presentation and this very important article together. So I'm going to ask our panelists to comment on a number of different achievements here. And the rule of this exercise is there are many things you could select from, but you only get to choose one. And I'd like to know what it is that you feel is most important, and why, and perhaps you might counter that, include that in what's most impactful in your own practice, and perhaps with an eye towards what has impacted thyroid management and the greatest number of people. So with that, I'm going to ask Mark Zafereo, can you give me, out of these 6 line items here, what you think is the greatest achievement, and for what reason here?
Well, thanks so much to Dr. Parangi for such a great presentation. First, I really so much enjoyed it. I think it's just a wonderful recap of where we've been, where we are, and that helps us also see where we're going. So thank you so much to Dr. Parangi for that. So to comment on one of these 6, it's very difficult. I'm gonna say I'm not necessarily going to say this has impacted the most people, because as we know that most patients have low risk thyroid cancer. So some of these other things that in terms of imaging probably have the most effect on the most number of people. But I'm going to take number 6 because that's an area where we've done a lot of research, and I think this is an area where we've made the most impact in advanced thyroid cancer, in the sort of the genetic molecular landscape of thyroid cancer. And we all know that that 90% of thyroid cancers are, quote, friendly or good cancers, and that patients are going to do great with a lobectomy or sometimes a total thyroidectomy, occasionally RAI. But for the 10% that have the aggressive cancers, we also know that those are the ones that die from thyroid cancer. So it's the 5 or 10% that have the aggressive thyroid cancers that are really the ones that are at risk of dying, and the other 90% are not. So within that group, that 10%, the impact of somatic mutational testing, I think, has been remarkable. And I think Dr. Parangi showed several examples of that in her presentation. I think we've made huge strides in particularly anaplastic thyroid cancer, looking at, BRAF, anaplastic thyroid cancer, and targeting that. Also, with RET cancers, RET fusions, targeting those. And I think, and this is really going to be the future. I think we've had such great results that we're really looking forward to what the next decade would bring. If we get the same level of innovation and improvement in patient outcomes and survival that we did over the last decade, and that if we get that in the next decade, it's going to be really exciting to continue to cure more of these patients.
Terrific. And great response here. I'm going to ask Dr. Shaha. This is a difficult question here to comment on what you think has had the greatest impact on enhancing the quality of thyroid cancer care. And remind you, you only get to choose one here, Ashok.
Okay, so my answer is multidisciplinary thyroid cancer teams. And I tell you why I say this. During my training, it was me and myself. We saw the patient, we evaluated them, we operated on them. And that's why Memorial was very strong about lobectomy, because they didn't go to anybody else. They stayed with us. They thought I'm the real doctor, and they followed me for the rest of their life and my life. Now things have changed because we have become humble surgeons. We know that no matter what we do, there is a 5% of patients group where we don't get success. And the job of a thyroid surgeon is to find out those 5 or 10% and be more aggressive. The thyroid surgical world has changed. It's not just the surgeon. It's the endocrinologist. It's the medical oncologist. It's a radiation oncologist. We always looked at those other teams as inferior. Now they have become superior. And we have learned from each other. And the classical example is what Zafereo and his team has done in anaplastic thyroid cancer, a deadly disease, which is now, we have survival for 4 and 5 years. We have never seen that before in our career. So to me, multidisciplinary thyroid cancer team is the most important in the quality of thyroid cancer care.
Terrific. Dr. Cunningham, are you in agreement here? Or do you want to challenge Dr. Shaha on that response?
What are you doing, Mark? You're studying the pot here?
I do want to say that quote is perfectly fit for Dr. Shaha, that you could see even when he started talking, both Mark and I had a bright smile on our face. So he makes people smile and makes them feel good. So your legacy is already set. I think the comments that both persons have made are totally relevant. I agree with both of those. I think that looking forward, if you don't mind me stepping ahead here a bit, is that while we've had this shift to less aggressive therapy, we need to continue to include multidisciplinary teams in terms of taking care of the wide breadth of people who have well-differentiated indolent disease, because we're making a lot of decisions on guidelines about active surveillance and such, and not really having the tools and the skills to really see what the outcomes of those things are. And by that, I mean, it is next to impossible, not feasible to do clinical trials on patients and follow them for 15 to 20 years. And I'm not talking about the anaplastic patients or the 5 to 10% that Dr. Shaha is referring to, but I'm talking about the vast majority of people with thyroid cancer. And that's what my team is trying to do, is use a simulated population to do so. So in terms of, okay, maybe we're going to observe small papillary cancers, but then why are we taking out Bethesda 2 and 3s? Right? So we have to answer these questions on a greater portion of patients moving forward. But I do think critical to this is multidisciplinary care teams, especially our pathologist. I learned so much from our pathology team.
Great, terrific. So Carrie, let me keep you on the microphone here. You have a hand in technology at MGH. I want you to pick one of these advances here and tell me what you think is most important, and perhaps what's impacted you more significantly than one of the others.
Yeah, I think that neuromonitoring, I use neuromonitoring myself and on every patient, but I think, we just had our section meeting this morning and our cases went up significantly and they were all, according to Dr. Gartland's RFA group. And, everything we're doing in thyroid surgery, I jokingly say, is we're not going to have jobs in 20 or 30 years, right? We're operating on fewer and fewer patients. So I think it's important for us to stay in that field of RFA, but that is going to become more and more widely used, and for good reason. For the majority of patients I spoke of that don't have lethal disease. So I think the ablative techniques aren't going anywhere, and they're going to continue to expand their uses, just like in Korea and other places where they're using them for small recurrences and small cancers as well.
Great. So Mark, can you comment on which of those technologic advances you think are going to become an enduring standard of care?
Well, not to sound like a broken record, but I have to completely agree with Dr. Cunningham. I think the one that I think is going to be enduring most likely is the ablative techniques. I think that we probably in the next decade or two will see an explosion of new technology in that area, with a lot of different techniques. You got thermal ablation, you've got non-thermal ablation. There's a lot of techniques now that are coming from other areas of cancer. Different types of. There's a technique called histotripsy, which is being used in liver cancer that doesn't even require sticking an electrode into the lesion and potentially ablating that lesion. So I think this area of technology in ablation is really going to, like Dr. Cunningham just said, I think it's going to significantly reduce the number of patients who have surgery. I think there will certainly still be a role for surgery, but I think that this is going to replace surgery in many cases for low-risk thyroid cancer. So I would say that would be the one I would say is going to be the most explosive in the coming decade.
Terrific. So I'm going to come back to you, Dr. Shaha, and this is, what do you think? You've got to choose one. What do you think of these items is the most significant in terms of the management of thyroid cancer?
Well, if you ask me one answer, I would go for the impact of BRAF inhibitors on anaplastic thyroid cancer. I think we can talk a lot about other advances, but that has changed our outcome. Lobectomy, total thyroidectomy, etc., has not changed the outcome. Outcome has remained the same. But the dreaded disease of anaplastic thyroid cancer now divided between BRAF positive and BRAF negative. I think the patients that we have treated with BRAF positive, they have done so well. We have practically avoided tracheostomy on them, or an airway issue is minimal. So I think we have changed the life of these patients. The average survival in the books was 3 months. Today, if I'm correct, it's more than 3 years. So I think that is the major advance.
Great. Dr. Cunningham, are you in agreement here?
Oh, absolutely. The case that Sareh presented is just incredible in the work that Mark's doing. I think that incredible work and more to come. And in addition, in medullary, right? We have a lot of clinical trials going on that are, neoadjuvant therapy for medullary thyroid carcinomas as well. So I think that's going to be the wave of the future. Again, we're going to be out of a job. Hopefully.
I think that will become very popular, Mark, is in inoperable or surgically unlikely to be successful. We have now new trials to reduce the size of the tumor and then probably do more convenient or more safe surgery. That will be another future, because we see a fair number of advanced cancers where the surgeon thinks he can do the operation, but he's in his heart, he's very unhappy about it. That will be another future.
Dr. Shaha, I think Dr. Tuttle is knocking on your door asking why active surveillance was not top on your list here. But I'm just going to bring this back.
That is Dr. Tuttle's idea. So
okay.
I agree about active surveillance, but I think you're asking a specific question where we have made a major impact.
Terrific. So I'm going to give Dr. Zafereo the last word here, and I'm just asking you to project. You already commented a little bit, but what do you think 20 years from now the future of thyroid surgery is going to look like here?
Well, I have to say, number 4 is going to be when you talk about low risk thyroid cancers. I would say a combination of number 2 and number 4, because I think with the sort of explosion of ablative techniques for low risk thyroid cancer, I think we're going to be increasingly looking at sort of molecular genetics to help determine, which cancers can be treated with ablative techniques versus which may need surgery. I think that's obviously we're a long way from that right now, but I think that is using molecular genetics to make those decisions is going to be increasingly important.
Terrific. I want to thank our panel. I want to thank our listeners. This has been just a wonderful discussion, and very humbling to look at how much has been accomplished and yet how much is left to go here. So thank you all, and I certainly hope everyone will join us again next week. Mark, Carrie, Ashok, thanks for your help here.
Thank you. Wonderful job, Mark.
Thanks. Enjoy, everyone. Be well.